Hello, we are Wiki Group 1. Our presentation for the Middle Range Theory Project will discuss the theory of unpleasant symptoms, specifically related to inpatient nurses assessing and treating alcohol abuse patients in rural communities. This module will provide and apply a framework for the practicing nurse in the inpatient setting. The goal is to improve a patient's overall health by recognizing symptoms in their entirety described by the theory of unpleasant symptoms, also known as TOAS, and treating and advocating for patients according to the entirety of their symptoms. By the end of this module, you will be able to demonstrate the magnitude of alcohol abuse in people aged 12 and older in rural communities and its relevance to nursing, describe the TOAS and the critical concepts that best relate to managing alcohol abuse symptoms, analyze and evaluate the theory of unpleasant symptoms using Fawcett's framework, provide rationale for using the theory of unpleasant symptoms to solve our practice problem, and present potential problems that may occur during intervention implementation and how applying the TOAS can help guide around those problems. We have provided a few readings that will help you further understand our module. In the provided articles, you will find information regarding alcohol abuse and withdrawal symptoms and how best to treat them, as well as information about the theory of unpleasant symptoms and its application in practice. The theory of unpleasant symptoms is a middle-range theory originally developed in 1995 and then revised in 1997. The purpose of the theory is to explain the causation and cyclical relationship of multiple symptoms that are simultaneously experienced by individuals. The theory posits that not only may one symptom lead to the development of another, but also that the treatment of one symptom may alleviate other symptoms. This module will apply and provide a framework for inpatient nurses in rural areas caring for alcohol abuse patients aged 12 and older. Our practice setting is patients in the inpatient setting who are 12 years of age and older and residing in rural communities. Our problem is alcohol abuse. Alcohol is the most commonly abused and used substance in the world. Consumption behaviors have dire consequences and have attributed to almost 90,000 deaths and 2.5 million years of potential life lost. Nearly 35,000 deaths a year in the United States are related to alcohol, not accounting for accidents and homicides. Alcohol use is believed to cause 230 different types of diseases, ranging from heart disease to liver and gastrointestinal diseases. In 2013, roughly 48% of all cirrhosis deaths were alcohol-related. Alcohol consumption harms not only the drinker, but also the people around the drinker. There are a reported 13,000 members of Al-Anon, a resource with weekly meetings provided to support family or friends of alcoholics. Alcohol abuse statistics are staggering, and with alcohol abuse occurring as early as 12 years old in recent data, the detrimental statistics do not appear to be decreasing anytime soon. Almost 1 in 5 Americans live in rural communities, which is defined by an area of less than 2,500 people. With roughly 20% of the United States population living in rural areas, nurses are almost guaranteed to treat this demographic. Rural Americans statistically lead in the 5 major causes of death compared to those living in urban areas. Since the rates of heavy drinking include binge drinking, which are higher in rural areas, the effects of excessive alcohol consumption can be closely linked to these 5 major causes of death. In rural areas, the patient-to-primary care physician ratio is 39.8 physicians per 100,000 people, compared to 53.3 physicians per 100,000 people in urban areas. Rural communities also have more uninsured and unemployed residents than urban communities, leading to less access to health care. With this disparity in care, it is vital for rural adults to receive effective care when in the inpatient setting to live a healthier life once discharged from the hospital. Inpatient nursing is nursing care delivered in a hospital or healthcare facility where patients are formally admitted to be treated for a medical diagnosis. Practicing nurses in the inpatient setting are responsible for performing physical exams and health history assessments, providing healthy lifestyle promotion and education, administering personalized interventions, and coordinating care with a wide array of healthcare professionals. Practicing nurses in the inpatient setting are positioned to recognize alcohol abuse and alcohol withdrawal symptoms, intervene to manage the symptoms, and enhance a patient's overall well-being or performance by treating those symptoms and advocating for their patients accordingly. Thus far, we have discussed the statistical significance of alcohol abuse. But to truly appreciate this problem, we believe one needs to hear the stories of individuals dealing with this on a regular basis. Please click the link below to hear the stories about alcohol abuse from former addicts.
Alcohol abuse is relevant to nursing in many ways. According to a report by Shine and Yoon 2017, in the year 2014, for people aged 12 and older, there were approximately 389,000 hospital discharges with a principal alcohol-related diagnosis, and approximately 2.4 million discharges had any alcohol-related diagnosis. The aggregate cost for all hospital stays with a principal alcohol-related diagnosis and any mention of an alcohol-related diagnosis were 3.4 billion and 30 million respectively. The average length of stay for principal alcohol diagnosis was found to be 5.8 days. Since alcohol abuse is highly prevalent, nurses must be aware of and be educated on how to care for these patients and on the financial obligations that are required when caring for alcohol abuse patients so that they can best allocate resources. Thus, nurses, by being aware of the complexity of alcohol abuse patients, can reduce inpatient stay times and maximize healthcare efficiencies. Inpatient nurses in rural communities working with alcohol abuse patients aged 12 and older must understand and utilize the theory of unpleasant symptoms to provide maximally beneficial and effective care for these patients. The theory of unpleasant symptoms is a middle-range theory originally developed in 1995 and then revised in 1997. The original framework of the theory linked antecedent factors to the symptom of interest, and the symptom was conceptualized as an experience that influences performance outcomes. The TAUS has been used as the theoretical framework to guide several studies of the symptom experience associated with a variety of illnesses. In the conceptual model of the theory of unpleasant symptoms, there are three major related parts: the symptoms, the factors that influence the symptoms or the antecedent factors, and the performance outcome. According to the theory, the three related categories of influencing or antecedent factors affect or influence the occurrence of one or more symptoms and how they are experienced. Multiple symptoms occurring together may have the same or different causes and may interact among themselves and can have cumulative or multiplicative effects. The symptoms in turn affects the individual's performance, which can feed back to influence the symptom experience and the influencing factors. The influencing factors, also known as the antecedent factors, are categorized as physiological, psychological, and situational. Physiological factors include the normal or abnormal functioning of body systems. They may include diseases and dysfunctions, treatments and medications taken in the past or currently, physiological and anatomical abnormalities, comorbidities, diet and nutrition, hydration, and amount of exercise. They also include age and gender of the individual. Psychological factors include mental state or mood, affective reaction to illness, and the degree of uncertainty and knowledge about the symptoms and their meaning to the individual. Situational factors include aspects of the social and physical environment that surround the person and may influence the experience, interpretation, and reporting of symptoms. They include environmental factors such as heat, humidity, noise, light, safety, and water and air quality. They may also include socio-economic factors, marital status, and social support. Comorbidities, pain, anxiety, lack of social support, and job insecurity are some of the influencing factors that could potentially influence the symptom experience of alcohol abuse and withdrawal.
In this next section, we're going to use Fawcett's criteria for evaluation of a theory looking at the Taoist framework. So when looking at the significance, we know that the criteria for the significance of the theory has been met. This theory addresses the meta-paradigm concepts adopted by the nursing profession. The Taoist addresses the broad concept of person as a patient who is exhibiting symptoms under the care of the nurse or the support system that surrounds the patient. The concept of environment is described in the Taoist by the understanding that there are multiple factors that contribute to the overall symptom experience. Examples of these are access to care, marital status, employment, and social support. Health is defined in the Taoist theory as the absence of symptoms. Finally, nursing is defined as the nurse that is evaluating the symptoms and the contributing factors. Furthermore, the Taoist illustrates the importance of the therapeutic relationship and the evaluation of symptoms. Although there wasn't a specific conceptual model mentioned in the Taoist theory, the way that the framework was created meets the additional criteria for significance. When the theory was first created, only one symptom was discussed, and as researchers and clinicians began to more widely apply this theory, modifications and improvements were made to the framework. The latest version of the Taoist now highlights the potential synergistic effect of multiple symptoms, and this allows for broader use of the theory and its application. The next portion is consistency and clarity. So in general, the Taoist theory meets the criteria for internal consistency. As mentioned prior, there was no specific philosophical claim in the conceptual model. However, the theorists explain that the development of the theory and how its evolution has allowed it to be applied more broadly. And the conceptual development and application are congruent with the main concepts of the theory. So one of the criteria for clarity that is to be met surrounds semantics, and the Taoist partially meets these criteria. Terminology changes throughout the theory description. One example would be symptom and symptom experience, and these are used interchangeably in the description of the theory. This semantic inconsistency decreases the clarity of the theory. Additionally, the sub-concepts are not as clearly defined as the primary concepts.
In order to assess the adequacy of a middle-range theory, the theory must be testable, the concepts must be observed empirically, the proposition must be measured, the theory must be empirically adequate, and the theoretical assertions must be congruent with empirical evidence. Lee, Vincent, and Finnegan summarized 31 articles that reviewed case studies that were guided by the Taoists. The statistical significance of each study is observed and tested, which warrants the theory's testability. In terms of empirical concepts, the assumption of the Taoists are met in that the symptoms can be experienced simultaneously. The dimensions, i.e., timing, intensity, quality, and distress, can be observed as separate or related. The influencing factors, i.e., physiological, psychologic, and situation, are associated with the individual's patient, and the researcher is able to examine the relationship between symptom and functional performance. In the Taoists, the propositions can be measured by the number of symptoms experienced. Furthermore, the theoretical assertions are based on empirical evidence, which is supported by nursing research. When assessing the feasibility and testability of middle-range theories, the following are addressed. Requirements for education and training prior to application of the theory in clinical practice, the clinical problems in which the theory is appropriate, the ability to implement clinical protocols derived from the theory, capability of nursing actions and expectations in practice, legal ability of the clinician in implementing nursing actions, and the ability for nursing actions to produce favorable outcomes. Regarding nurse education prior to application of the Taoists in a clinical setting, Nurses must be equipped with knowledge regarding not only the concepts of the Taos, but also symptom assessment, how to create nursing diagnoses, and how to implement appropriate interventions. The general nature of the Taos allows it to be applied to virtually any clinical problem or setting. Lee, Vincent, and Finnegan evaluated 31 different studies in total spanning the globe, including populations with diverse health concerns and demographics. Therefore, the Taos can feasibly be implemented with adequate knowledge and training. If a nurse has adequate training in the subject matter and subject setting, their actions will be compatible with the expectations of high-level nursing practice. The clinician has the legal ability and obligation to implement the Taos in nursing actions. Assessing multiple symptoms and implementing appropriate interventions are well within the nursing scope of practice. Thus, the Taos also leads to favorable outcomes because it encourages nurses to consider multiple symptoms and appropriate interventions which lead to individualized, patient-centric care.
So to conclude the portion of the evaluation of this theory, we know that the theory of unpleasant symptoms provides a theoretical framework that has guided several studies of symptom experience associated with a variety of illness such as cancer, COPD, different types of surgeries, multiple sclerosis, and Parkinson's disease. The Taos may also be used as a framework for studies involving women who experience IPV or intimate partner violence, pregnancy, and the postpartum period. Several studies have used this theory, and findings showed that the symptoms, variables that influence the symptoms, and performance are interrelated. Additionally, the Taos has been proved to be measurable. Many assessment tools have been created with the Taos as the foundation. In a comprehensive evaluation of the Taos theory, multiple statistical tests were used to examine the relationship between the theoretical concepts, and the results demonstrated statistical significance of the interrelatedness of main concepts. This further just supports the use of the theory in developing assessment tools and interventions in the clinic setting. The rationale in using the theory of unpleasant symptoms is to help inpatient nurses in the rural setting manage alcohol abuse and improve the care and overall health of patients aged 12 and older. The Taos can be used as a framework for nursing assessment and effective intervention decisions. Symptom experience is subjective to the individual and is at the forefront of this theory. The Taos provides an understanding of how a patient's symptoms has an additive and enhancing effect on each other and their relation to other factors in the individual's life. When alcohol abuse patients are admitted to the hospital, they often experience withdrawal symptoms. Withdrawal symptoms commonly include headache, seizures, restlessness, confusion, and nausea. The dopamine imbalance that is caused by withdrawal makes these patients irritable, non-compliant, and difficult to work with. When patients have a long list of symptoms, some nurses find themselves administering a large number of medications to counter those individual symptoms. A nurse who utilizes the Taos realizes that the symptoms are related and may administer fewer medications, understanding that by changing the timing, quality, distress, and severity of one symptom will likely decrease the others. By using less medications initially, the patient may experience fewer side effects from the medications, as well as the nurses being more efficient with hospital resources. Another way to think about this is in regards to medications being weaned on an alcohol abuse patient. In alcohol abuse patients, benzodiazepines are a common medication used. Despite a nurse weaning this medication because seizures are less likely, the patient may then experience greater intensity in other symptoms such as headaches, restlessness, and nausea. By utilizing the Taos, nurses are more prepared to combat other presenting symptoms that may intensify when weaning medications intended for other symptoms. When considering the physiological dimension, or psychological dimension, of alcohol abuse patients, nurses who are transparent can explain the Taos, may be able to provide a certain level of comfort to the patient during this process. Nurses can explain the relationship between the symptoms and that helping a patient with nausea may also be able to battle headaches and restlessness, which may increase patients' compliance with nursing interventions and medication administration. Nurses who are able to verbalize their plan of care and demonstrate to the patient that they are taking all their symptoms into account are showing their attentiveness to patients and thus building a stronger nurse-patient relationship. Additionally, the TAOIS is a strong framework for identifying influencing factors that exacerbate symptoms. Influencing factors include psychological, physiological, and situational factors. These factors can help nurses decipher the root cause of alcohol abuse and withdrawal symptoms, therefore allowing more patient and specific interventions. If the patient is abusing alcohol to cope with a situational factor such as job loss, then the nurse may advocate for a psychology consult to help the patient cope in a healthier way. If the patient is abusing alcohol to cope with a physiological factor, maybe for example back pain, the nurse may advocate for a pain specialist to help the patient deal with their pain in a more effective way. The influencing factors also describe the symptoms that can be expressed differently between someone's age and gender. In our problem, research shows that in rural areas, women tend to speak less and seek health care less because of the stigma that comes with seeking help or treatment. It is important for nurses to understand the complexity of symptoms in their entirety and provide the most effective care for their patients. Finally, there is a relationship between the symptom experience and patient performance. Understanding how alcohol and abuse and withdrawal affects a patient's performance, such as ADLs and cognitive performance, allows a nurse to supply a patient with the proper resources to succeed post their inpatient stay and decrease the probability of readmission for the same problem. The influencing factors, symptom, and performance described by the theory of unpleasant symptoms are all related to and affect one another. If nurses can accurately assess their patients, intervene specifically, and provide correct resources by collaborating with other healthcare providers and advocate for their patients, beneficial change for battling alcohol abuse in rural areas is not as unattainable as perceived. Using this theory as a guide, inpatient nurses can better care for alcohol abuse patients in rural communities.
So the proposed solution assessment tool number 1 is the short form 36 or SF36. It's a 36-item survey that a patient fills out, and the survey questions pertain to self-belief on a patient's health status over the last month. The survey addresses a patient's belief towards their general health, limitations of activities, physical health problems, emotional health problems, social activities, energy, and emotions. The 36 questions are clear and provide insight into multiple dimensions of how a patient perceives their health. This survey would be pointedly insightful in our problem because it would allow nurses to understand the subjectivity to which the patient is describing their given situation. The TAOIS is a theory based on a patient's subjective perception of their situation. If a patient is describing their situation as not detrimental, but upon observation the patient appears to have many deficits, the nurse has knowledge moving forward that this patient does not have a clear understanding of what is occurring or have strong perception of their own health. In future experiences, the nurse will be able to better decipher how the patient is expressing themselves when they're verbalizing how they feel about their symptoms. Second, the survey allows a nurse to understand how the patient perceives their performance component of the theory. Questions in the survey address psychological and physiological issues specifically. In the TAOIS, the patient's performance affects the influencing factors. By understanding patient's performance, a nurse can better understand the influencing factors contributing to the symptoms. Our second proposed solution is the assessment tool of PAUSE, or the Prediction of Alcohol Withdrawal Severity Score, which is applicable to all patients, whether identified previously or not from other departments. And it helps determine the risk of experiencing withdrawal symptoms during their stay for any of these patients. A PAUSE score of 4 is typically the threshold that would then initiate pharmaceutical intervention, which is discussed later. and would also trigger an AWS, which is part of the pharmaceutical algorithm as well. The AWS, or the alcohol withdrawal screening, is applicable for previously determined at-risk patients. These at-risk patients are identified as such due to either a PAUSE score of 4 or greater, an existing diagnosis of alcohol dependence, if they're experiencing active withdrawal, if they've been screened for a substance abuse or another screening tool that an emergency department may use prior to their admission to the inpatient unit, if they're actively intoxicated during their visit or initial entry onto the inpatient unit. The scoring is based on 6 overall components with a total of a max score of 18 points. Those 6 components fall under the categories of tremor, tachycardia, diaphoresis, agitation, confusion, and hallucinations, which can be visual, auditory, or tactile. The overall score, with a max of 18 for all of these 6 components, determines the intervention and the frequency of assessment of and reassessment of the AWS, which we will discuss later. So what do these proposed solutions look like in inpatient implementation? So the short form 36, all patients admitted to an inpatient unit who have a history of alcohol abuse or dependence identified in their medical history or as previously identified from the emergency department team will undergo the short form 36 screening upon admission to the inpatient unit. It will be completed at the time of admission to the unit, either by the patient themselves or with the assistance of the RN if literary or language barriers exist. For inpatient purposes, the nurse will explain the purpose of the survey to the patient, supply the survey, and ask the patient to fill out the survey to the best of their ability, collect the survey from the patient and interpret the results. A score of 100 means no disability, and the lower the score, the more the disability. So a score of 50 would have more disability than a score of 75, for instance. They will use the survey as a starting point to assess the severity of alcohol abuse symptoms. Lastly, they'll inform collaborating providers on results of the survey to create and guide a healthcare plan for that individual. Collaborating providers can be anything from MDs, practitioners, to social work or substance abuse or case management or religious services as well. So it's a collaborative, multidimensional approach. The inpatient implementation of the PAUSE and AWS will look something similar to the SF-36. However, the PAUSE will be administered to all patients who are admitted to the inpatient unit. A PAUSE score of 4 or greater that will then go ahead and trigger a pharmacological algorithm to treat withdrawal symptoms. Additionally, physician orders will then be initiated as well to include a modified AWS tool, which is to be assessed by the RN at the time of admission for that patient, at baseline, and periodically as determined by the AWS guideline. The baseline is determined at the time of admission. That's what that patient's baseline will become. AWS scores will determine the frequency of reassessment and the pharmacological treatment and dosing. As previously mentioned, the modified AWS includes the following 6 components with corresponding point systems. So tremor, if there was no visual, no tremor whatsoever, that patient would earn a score of 0. However, if there was a mild visible tremor, then that person would earn 2 points, and so forth for each of the components. And then cumulatively, you would receive a score. And based on that, for instance, a score of 0 to 5, no pharmaceutical intervention is necessary, and reassess in 4 hours. A score of 6 to 12 requires an administration of 5 milligrams of IV diazepam and reassess in 2 hours. A score of 13 to 18 would require 10 milligrams of IV diazepam be administered to the patient and reassess in 30 minutes. A score of 18 obviously is the max, and there should be strong concern for withdrawal seizures, and prophylactic anti-epileptics may also be given in addition to the benzodiazepine of that hospital's choosing. So there are potential implementation problems with these solutions. First, the survey, the SF36 survey, does not directly assess influencing factors. Instead, the survey generally assesses the performance component and makes the surveyor interpret influencing factors. Being able to identify and clarify influencing factors properly allows for specific and effective interventions to be implemented quickly. Regarding the symptom component of the TAOIS, the short form 36 only assesses the characteristics of one symptom, pain. Symptoms caused because of alcohol abuse and withdrawal, such as anxiety, depression, hallucinations, or nausea, and so forth, are not questioned in this survey. Aside from the components of the TAOIS that create implementation problems, the survey also requires truthfulness and engagement from the patients. The survey requires that the patient is forthcoming about their status. A patient may be in denial or afraid of the consequence of performing quote-unquote badly, and may change their answers according to what they think the surveyor wants to hear. Another implementation problem is that the survey does not account for all age demographics. Older persons taking the survey may have difficulty performing activities because of age-related factors and may erroneously appear to have a disability, which is not alcohol use related. Our problem also addresses persons as young as 12 years of age. Teenagers may have a different belief in what it means to be a, quote, happy person or, quote, full of pep compared to a person in their mid-30s. So there is some age variation that may serve as a potential problem. The timing of when we administer the survey also questions the validity of the survey. Often patients who are admitted to the hospital for alcohol abuse are currently intoxicated or perhaps even going through active withdrawal at the time of their inpatient status. To get uniform results that can be easily interpreted, we're assuming that patients are of sound mind and stable mentation when answering questions. If we administer the survey during alcohol withdrawal, the results may be skewed as more extreme because the patients are currently in a state of experiencing the worst of the symptoms. Additionally, some possible issues that may arise to the AWS assessment are lapses in medication management or reassessment may occur as a result of shift change or staff-to-patient ratios. There can be inconsistencies among RN's objective assessment of a patient utilizing the modified AWS, which may result in under or over management of the alcohol-dependent patient. And the modified AWS does not differentiate between early and late signs of withdrawal. So how did TAOIS, or the theory of unpleasant symptoms, guide our intervention? It guided our intervention development by recognizing the need for a multidimensional approach by managing both the symptoms of withdrawal and the overall dependence on alcohol. TAOIS highlights the importance of realizing the interrelationships of symptoms with one another and the potential of an overarching relationship. First, the TAOIS guided us to recognize the need to anticipate symptoms prior to clinical presentation as it stresses the cumulative nature of symptoms. In initiating the pause for all patients, screening is not limited to only those already identified. It addresses all patients and propagates improved detection of alcohol withdrawal for the admitted patient. Second, due to the complementary and additive nature of symptoms as described by the TAOIS, the modified AWS was incorporated in the intervention. Through the modified AWS assessment, RNs and care teams can more accurately manage withdrawal symptoms and anticipate the needs of their alcohol-dependent patients throughout their stay and continued withdrawal. Third, the TAOIS guides us in looking for a component of the intervention that acknowledged other symptoms that may also impact the alcohol-dependent patient on a long-term and less acute scale. The TAOIS sheds light on the interactive nature of symptoms and how they may act as a catalyst to other symptoms. AWS focuses on the physiological effects of withdrawal and the additive effect they may play in patients' overall wellness while in the inpatient setting. Healthcare services such as team consults and pharmacological therapy, such as specific medication administration, can be initiated quickly and effectively through the use of PAWS, modified AWS, and short form 36 survey when treating alcohol abuse and withdrawal patients in the inpatient setting.
Let's check your understanding of the theory of unpleasant symptoms. First question. What type of influencing factor is marital status of a patient considered? A. Physiological factor. B. Psychological factor. C. Situational factor. D. Performance factor. If you selected C. Situational factor, you are correct. Blank are at the forefront of the TAOIS. A. Symptom experiences. B. Influencing factors. C. Patient performances. D. Nursing interventions. If you selected A. Symptom experiences, you are correct. The modified AWS includes all of the following except A. Tremor and tachycardia. B. Diaphoresis and agitation. C. Confusion and hallucination. D. Headaches and depression. If you selected D. Headaches and depression, you are correct. The acronym PAWSS stands for what? If you answered prediction of alcohol withdrawal severity score, you are correct. The theory of unpleasant symptoms is A. Ethical theory. B. Middle range theory. C. Socio-cognitive theory. D. Learning theory. If you selected B. Middle range theory, you are correct. Last question. The TAOIS leads to favorable outcomes because it encourages nurses to consider what and appropriate interventions which lead to individualized, patient-centered care. If you answered multiple symptoms, you are correct. Congratulations.